Alrighty. Hey, what's up, guys? How you doing? Thank you for joining me. This is Meds Mnemonics. Gonna do another video. I finally got off my ass and see if we can actually make another one. So, yeah, let's get on it. But first, before we get into the video, I just want to say, if you like this content, click the like button. If you want me to make more videos and pretty much have an incentive to make more, then subscribe. It'll give me a little bit of a litmus test to see if I should actually make more videos and if you guys actually like this. So, without further ado, let's just go forward. That's that. You guys can read. Okay, so real quick, this is a medical disclaimer. Pretty much it spells out, if you have a serious problem, go see a medical professional and don't sue my ass. Again, this video is going to have a lot of profanity and adult language, so if you don't like language and swearing and all that fun stuff, sorry to tell you, tough shit. Okay, so today's topic is going to be drug overdoses. This is going to be a topic that gives students a permanent headache, literally. So essentially what's going to happen is they're going to give you a vignette on your test or your boards, or actually in the hospital where someone's going to come in passed out, they're going to have a bottle next to them. You're not going to have an entire idea of what the hell it is. So the whole point of this video is I'm not going to go thoroughly through all the pathophys and all that fun stuff. There are other places on YouTube land that can actually explain all that. The whole point of this video is I really want to talk about, the actual symptoms and some clues in the vignettes to look for to actually pin down what drug you're actually looking that they actually overdosed on. And then some memory hooks and how to actually remember what the antidote or the solution is to those drugs. So let's move on and get going on this. Okay, so here's going to be the drug list. It's going to be here on the right. So we're going to go through aspirin, Tylenol, booze, benzos, cocaine, amphetamines, PCP, opioids, organophosphate poisoning, anti-cholinergic poisoning, and antidepressants, which are TCAs. All right, so let's dive in. Oh yeah, I forgot, real quick. Two things you should know. You can do a drug test, and the way to remember this is you can use the word DATE, so DATE. When you do a drug test, whether it be urine analysis or what have you, it could be something you can test for are drugs, aspirin, Tylenol, and ethanol. You'd like to get these levels fairly quickly. It can give you an indication as to what you're dealing with. And also, you want to obtain a glucose level because it can mimic overdoses. Okay, so the first drug we're going to talk about here is aspirin. So it's an ASA and it's an NSAID, so it's a non-steroidal anti-inflammatory drug. Typical pill is about 350 mg. This can vary. And the reason I'm mentioning this is because the toxic amount is about 10 to 30 grams. So you have to take about 30 pills for this to really take effect. So real quick, I just want to go through a little bit of physiology to explain aspirin. So here's a very important equation. You're going to have water plus carbon dioxide is going to transition to a proton plus bicarbonate. So what you want to do is, I'm going to use the cursor right here. This guy right here, this is the proton. This actually represents the actual acid that you want to worry about that's going to build up. So when you take aspirin, this is actually going to skyrocket. You're going to have a ton of acid. And you actually want to get rid of this. So the way you're going to do this is through Le Chatelier's principle, that if you, on the left, if you get rid of any of these two, water is going to be a little difficult to get rid of when someone's passed out. But what you can do is you can get rid of CO2. And the way you do this is through hyperventilation. And if you do this, it's going to be respiratory because you're going to do it through your lungs, and you're going to have alkalosis, meaning that you're going to become more basic. Because if you get rid of the protons here, shift the equation to the left, and get rid of CO2, you're going to induce having less acid around, therefore making it more basic. And then later on, what aspirin is going to do is it's actually going to shut down oxidative phosphorylation. And you can look up in a biochem book exactly what that means. So essentially what's going to happen is it's going to go from like an aerobic state to an anaerobic state, and it's going to build up a ton of lactic acid, which is more acid on top of that. So it's going to cause what's called a high anion gap metabolic acidosis. So keep in mind, aspirin is an acid, so the treatment of it is going to be a base, which is going to be sodium bicarbonate. So the treatment's going to be here. For aspirin, you would use the S in aspirin for sodium bicarbonate. That is the memory hook on how to actually treat someone who overdosed on aspirin. And the reason I started with aspirin first is because aspirin and Tylenol, which is going to be next, these are the two most common drugs of overdoses. Not the most common, but they're one of the main two. And the reason for that is because if you open just about any cabinet in about any household, you're going to be able to find aspirin and Tylenol. You can get them over the counter at Walgreens or any kind of department store. So it's actually very common. This should be high in your differential when you're looking at a question or you're seeing a patient in the hospital. for a potential overdose. So I just wanted to kind of plug that in as to why I started with aspirin. Okay, so next is going to be Tylenol, which is acetaminophen. First off, it's not a fucking NSAID. This gets confused a lot. It does not have any anti-inflammatory properties. So if your knee is swelling or what have you, Tylenol's not going to do shit. So I just want to let you know that right off the bat. People confuse Tylenol and group it in with ibuprofen and other NSAIDs. They're essentially similar, but they're not the same class. Again, Tylenol is not a fucking NSAID. So what Tylenol is actually used for is it's used for analgesia. I just think anal is painful. I don't know from personal experience, but I can imagine that it's not very comforting. So if you look at the first part of that word, anal, just think anal is painful. So analgesia means you want to treat pain. And then antipyretic, think pyro, which is someone that lights stuff on fire, is fever. So Tylenol is used for pain and for fever. It's not used for anti-inflammatory properties. So a typical pill, again, is 325 mg. This can change. And toxic amount is 7.5 to 10 grams. Okay, so again, I'm going to do a little bit of physiology so you understand what's going on here with Tylenol. So if someone comes in and they're passed out and you suspect that it's going to be Tylenol, they're going to eat like a whole ton of the bottle. So what typically happens with Tylenol is usually metabolized through the liver and then you pee it out. If you take the normal amounts, it's no problem. The problem is when you take toxic amounts. I mean, you're talking like grams, like 30, 40, 50 pills. Someone ate the entire bottle. What happens is instead of using the main pathway to metabolize to the liver, it has to use an alternate pathway. And this is through the CYP450 enzyme. And what happens is it actually builds up what's called NAPQI and glutathione. So what happens is this NAPQI, it'll build and build and build. You need to conjugate it with glutathione to essentially eliminate it so it can be peed out. The issue is glutathione is actually going to run out. So NAPQI actually is toxic to the liver, hence it's going to cause liver damage. So when you ingest a shit ton of Tylenol, this NAPQI is just going to skyrocket and glutathione can't keep up to conjugate it to get it out of the urine. Therefore, it causes liver damage. And a little side note at the bottom is alcohol will actually make this worse. It'll actually shift to the alternative pathway, which will actually make it worse. So if someone chugged a fifth of whiskey and took a whole bottle of Tylenol, it's actually going to make this process even worse and more toxic. So I just wanted you guys to have a basic understanding of how that works. So again, the treatment is going to be N-acetylcysteine. So its job of what it's going to do is it's actually going to reboost that glutathione so you can actually keep up with the NAPQI and help conjugate it, and then you can pee it out. So the way to remember this is if you look at the word acetaminophen, look at the last letter, it starts with an N, just loop back around to the front with AC. So that's how you remember that NAC is the treatment, okay? N-acetylcysteine increases glutathione, helps conjugate the NAPQI, and then you can pee it out, and hopefully you can prevent the patient from going into liver failure. Okay, next is going to be ethanol, which is booze. You've all seen the symptoms. Somebody's drunk, they came from a party, they're going to come, be lethargic, and be all goofy and laughing and or passed out. So the mechanism of how this works is actually a GABA receptor agonist. So just think GAGA, it makes you chill like a baby. So essentially, it's a depressant. What you're going to be concerned about is withdrawal. So about 3 days out, it can actually exacerbate what's called delirium tremens. It's the little pink elephant. You've seen it on glasses at bars. And this actually can induce a seizure. And that's actually one of the things you're worried about. That and respiratory depression and possibly aspiration from their own vomit because they're just completely knocked out and they're not really controlling their, bodily fluids and functions. And you're worried about them aspirating into your lungs and causing pneumonia and other serious issues like that. So for the treatment for alcohol is booze. So you're going to give it benzos. Benzo is going to help with the seizures and it's going to help them kind of snap out of it with alcohol. And also, if you have an alcoholic, like someone that just frequently comes to the hospital and they're always coming in and getting benzos, what they're also going to need is they're going to need two other things on top of this because they are malnourished. So the mnemonic for this is going to be toast, and then you're going to do a shot. So thiamine, which is going to be B1, which is a vitamin, and then you're going to give sugar, which is going to be glucose. And like I said before, heavy drinkers are malnourished, so they need these to be replenished to make sure that they don't have any other side effects on top of the seizures and respiratory depression. So remember, alcohol, booze, benzos, toast, then a shot. So you're going to take thiamine and you're going to take sugar, which is glucose. That's ethanol. Okay, so now on to benzodiazepines. Again, it's a GABA receptor agonist, so it's a depressant. It's going to make you feel chill like a baby. The major concern with this is someone took too many benzos, you're going to have respiratory depression. You're going to stop breathing. And the treatment for benzos, ironically, is you want to give them benzos. I know it seems a little counterintuitive, but that's actually what you want to give them. And let's say they onboarded way too many benzos. So they have way too much to a point where you need to reverse the effects and block benzos. So what you can do is you can use this antidote called fumezanil, and this is, I probably butchered that, my bad. It's a GABA antagonist. So just a way to remember how this actually works is that benzo rhymes with flamenzo. So if you just kind of remember those two, you can remember that it's fumezanil that is the one that actually is going to be the antidote for an overdose of benzodiazepines. But you do have to be careful if you onboard this antidote and you block the benzos, which is used for stop breathing and seizures, you can actually induce a seizure withdrawal because you don't have the benzos to calm down the body and the receptors to not do that. So just be aware. This might be something you might get a question on your test or your boards of if you give the antidote, one of the things you're worried about is a seizure withdrawal. So that's benzodiazepines. So again, a good mnemonic for alcohol and benzodiazepines is benzos and booze get the bees. They both get benzos, okay? Okay, so on to cocaine, which is also known as blow. So for its function, it's going to increase epinephrine and dopamine in the synaptic cleft between two neurons. So essentially, it's just going to make you really up and amped up. So the time duration is about 1 hour, and I mentioned this because it's actually important to differentiate from another drug, which is actually coming up next. So the symptoms, they're going to be agitated, they're going to be walkie-talkie. If you walk into a party and someone's all like sweating and jacked up and talking a million miles an hour, well, it's possibly they could be on cocaine. One of the main symptoms you're going to see is called pupillary dilation. So if you look at somebody's eyes, if you look at the pupils, they're just going to be big as shit. And that's like actually a big clue that this could be one of the few drugs that's going to be on the list of having big pupils. And also you're going to have tachycardia and hypertension, meaning that you're going to have a high heart rate and your blood pressure is going to go up because you're really being amped up by this medication. So like I said, the main symptom is going to have pupillary dilation. So if you look at cocaine and look at the word, just take the A and pick that out and just remember that it's amped up. And you're going to have bigger pupils, which is dilation, which is another A. So if you make these connections, if you see in the vignette or you see a patient with just really big ass pupils, cocaine's got to be on the top of your differential of one of the few that it could be. Now for the treatment, again, I'm going to go with the theme of the A. You're going to give them Ativan, which is actually a commercial name for a benzodiazepine, and you want to give alpha blockers, which is actually going to block cocaine's constrictive effects. So being all amped up, Ativan and alpha blockers are actually going to do the opposite and essentially eliminate those and help you kind of come back to normalcy when it comes to all your bodily functions of hypertension, tachycardia, and things of that nature. So just to really hammer this home, I just want to show you that one more time. So take the word cocaine, use the letter A, and it's going to be amped up. It's going to be big dilated pupils, okay? Just think big. Cocaine, big eyes. And they're going to use Ativan, which is a benzo, and alpha blockers. And lastly, you do not want to give them a beta blocker because cocaine goes after the alpha receptors, and there's also beta receptors. And if you block the beta receptors, hence the name beta blockers, you're actually going to leave the alpha receptors unopposed, meaning they can do whatever the hell they want. And they're actually going to make all the symptoms worse. Like tachycardia is going to go way too high. Your heart rate's going to go way up. Your blood pressure is going to go sky high. You're actually essentially letting go of the alpha receptors so they can just go bananas and do whatever the hell they want. So again, do not give beta blockers to someone that's potentially on cocaine. It's going to make it worse. Okay, next is amphetamines. So just think meth. You can just think of Breaking Bad. So again, just like cocaine, it's going to have a stimulus effect, and they're going to have symptoms of being delusional, hallucinations. They're going to be amped up, just like cocaine, and they're going to be paranoid. So there's going to be two main symptoms you want to look out for in a vignette. So just look at the word meth and think TH. First is going to be tactile hallucinations. This means creepy crawlers, meaning that they are hallucinating and they think they actually have bugs on their skin, and they're just going to be scratching themselves and picking at themselves, and they'll actually have lesions on their extremities of their body because they think they see something because they're hallucinating from being on the amphetamine, but it's actually not there. So it's called tactile hallucinations. And then also they're going to have bad teeth. I mean like rotting, disgusting, messed up teeth. So these are going to be the two symptoms that if you see this, someone's been picking at themselves and have lesions all over their arms, and they're really amped up and they have bad teeth, you need to start thinking methamphetamines. And again, amped up. This is the other drug that's going to have giant pupil dilation, big eyes, and they're going to have pretty violent behavior. And also, this one's going to last for hours. So if you get a similar presentation and you're not sure exactly if it's cocaine or amphetamines, if it's only been about an hour and they have pupil dilation, it's possibly it's cocaine. If they've been up for hours or days and they have, lesions all over their arms and really bad teeth, and it's been going on for almost a day or so, then you have to start thinking methamphetamines. And again, use the A in amphetamines. It's going to be, again, used for Ativan, which is benzos. But the one that's different with amphetamines, because of the hallucinations and then being paranoid, you want to use antipsychotics. Just remember the two A's. So again, real quick, I just want to reiterate this in a different way so it's easier in the eyes for you guys to remember this. Amphetamines has the A. You're going to use Ativan, which is benzos. And you want to use antipsychotics. Okay, and that's what we're going to be looking for. And also, just to recap for cocaine and amphetamines, they're going to both be amped up. They both have A's. They're going to have pupil dilation, big eyes. And again, like I said before, cocaine's going to last roughly about an hour, and meth is going to be hours to days. That's how you differentiate if you're not sure which one's which. The timeline of how long they've been essentially stimulated is actually going to help you steer to whether it's cocaine or amphetamines. Okay, now we're on to PCP. So again, function is going to be a stimulant. It's going to increase sympathetics. So their symptoms is going to be like violence, psychomotor agitation, analgesia, and they're going to have, which is a big clue, which is called nystagmus. This is going to be repetitive, uncontrolled eye movements going back and forth. So this is the biggest clue. If you start reading a vignette or see a patient that's having nystagmus and they're not being induced with ketamine or something of that nature, this is a pretty big clue that this is potentially PCP. Now, I'm going to show you on the next slide how to actually remember this, that nystagmus should be tattooed with PCP. So it's going to look like the letters PCP. It's going to look like eyes moving back and forth. And I'll show you in a slide in 1 second. For the treatment, you're going to use PCP. So for the first P, that's going to be for antipsychotics. There's the P right there. Take the second P that's after the C and flip it around, and it's going to look like a B. So that's going to be benzos. So remember, antipsychotics and B for the benzos. That's how you remember PCP gets the P and the B. I really wish I made it a PB and J, but I didn't have enough time to think of it to be more clever. But we're going to go with the PCP and just flip the 1, and that'll be a B. That's how you remember how to treat PCP. So again, the biggest clue here is going to be nystagmus, meaning the repetitive eye movement that goes back and forth. So if you actually take the letters PCP and you just kind of visualize that the P's are actually eyes, just imagine them dancing back and forth. And I'll show you that right here, which is a little bit of cartoon. So here they are with the P's. I put some dots in them to look like eyes, and they move back and forth, back and forth. That is nystagmus. If someone comes in and they're being very violent behavior, they just seem really off their rocker, and their eyes are moving back and forth, start thinking PCP. And you want to onboard antipsychotics, and then flip that P, you want to give them some benzos. That should chill them out nice and good. So remember, nystagmus, PCP, antipsychotics, and benzos. This is how you treat someone that is potentially on PCP, okay? All right, opiates. Okay, this one's a pretty big one. This one does happen quite frequently when people come into the emergency room or the hospital. So let's dive into this one. So use is going to be a pain reliever and analgesic. Remember, anal is painful, so it's for pain and it's for a sedative. Its function is going to be a mu receptor agonist. There are other receptors like kappa and what have you, but we're actually not focusing on those. With opiates, the one you're really concerned about is the mu receptor. And this one essentially pumps this one up, and that's what induces like pain relief and a sedative and kind of calm you down. Examples of this would be heroin, fentanyl, and morphine. These are just either preconjugates of each other. Essentially, they're all going to get metabolized to morphine, and some are way more powerful than the others. I just wanted to mention a few examples here. So the symptoms, you're going to have miosis, which is pinpoint pupils. So this is the first one where the eyes are going to be like really, really constricted. The pupils are going to be like, like the tip of a pencil. I mean, very, very small. They're going to be lethargic, and the thing you're really actually worried about is actually respiratory depression. This is the main symptom, and you're worried about this because if they take too much of an opioid, they can actually stop breathing and actually die from this. That's why this is actually really important that you recognize that this is what it could be and correct it accordingly and quickly. So for the treatment for opioids is going to be for the O. You're going to use that in overdose when they take too much. You're going to use naloxone, which is aka Narcan. You've probably seen on like TV shows in the ED or EMS where they come up to a patient and they start shooting a medication up their nose to make them snap out of it. This is naloxone. That's what Narcan is. Again, it is a mu receptor blocker. It's an antagonist, so it's obviously going to do the opposite effect of what an opiate does of a mu receptor agonist. So again, to kind of help you remember that the meiosis or the pinpoint pupils is if you look at the word opiate, you got the two lowercase i's here. Just look at those eyes. They look like little dots, and this should actually ping your memory as a memory hook. These are going to be pinpoint pupils. And I provided a little picture just for that memory hook. So again, take the word opioids and look at the two dots, make them into eyes. You can see they're nice and small, and they're just like little ends of pencils that someone just poked in your eyes. If you see this, start thinking, along with respiratory depression, that this person has an opioid overdose. Okay, this is organophosphate poisoning. This one's actually a real pain in the ass to explain, so I'm going to do the best I can and do this as quickly as possible. So I'm going to show you just a quick little bit of physiology on this page, on the next page, and then we'll dive into exactly how this overdose presents with its symptoms and how you actually fix it. So real quick, we're going to have the autonomic nervous system, which is something that just kind of goes on in the background. This first one is going to be the sympathetics. Just think fight or flight. So if a bear is chasing you, you want to be as dry as possible, meaning when you're running from them, you're not going to want to take time to pee or poop right now. You're going to want to increase your heart rate. You're going to want to dilate your eyes so you can see more when you're running away from the bear. You want to be extremely alert. You don't have time to cry or tear about it or pee or poop, like I said before. You essentially want to shut all that off, and you want to reroute all your blood flow into your cardiovascular system and away from your GI tract. You do not want to spend time digesting right now. There's no point in that if a bear gets his hands on you and mauls you to death. So the whole point is to put everything on pause and to give you enough circulation so you can actually start running and get away from the bear. Remember, no crying, no sweating, no peeing or pooping, no digesting. Essentially, you want to increase your heart rate, increase your blood pressure, and get the hell away from that bear as fast as possible. So you can see here that you have the two neurotransmitters, which I have here, are going to be the acetylcholine and norepinephrine. So I'll tell you why this is important in a second. But you can see the second one is norepinephrine and not acetylcholine. And you're going to have dry symptoms, like I said before. No peeing, no pooping, no crying, no sweating, salivating, no digesting foods. Essentially, you want to just hold on to everything you have and run for your life. So here on the other side, this is the opposite of sympathetics. This is parasympathetics, which is rest and digest. This part of your autonomic system is like when you're just chilling on the couch, watching TV, eating a pint of ice cream, and watching your favorite rom-com. So what you're going to notice here is you're going to have two acetylcholines. And this is actually really important because this is one of the main points of organophosphate poisoning. You're going to notice that if you were to have an abundance of acetylcholine, which is not in the sympathetics, that's actually norepinephrine. If you have a ton of this, it's actually going to give you wet symptoms. So you're going to be peeing, pooping all over yourself, crying, sweating, vomiting. Any way you can get liquid out of your body, it's going to do that in excess if for some reason you had an abundance of acetylcholine laying around. So that's actually the main point of this slide, to point that out. So again, I'm going to go through this one more time to try to hammer it in to make sure it's actually clear what the hell I'm talking about. So with the autonomic systems being your fight or your flight or your rest and digest, it really depends on acetylcholine. And if you have an abundance of it, it's really going to increase your rest and digest and really not going to have much of an effect on your fight or flight symptom. So you can see that here. If you go to the left, you're going to have sympathetics, which is more dry because you're trying to run from a bear. You don't have time to pee or poop right now. You're not going to have a lot of acetylcholine sitting around. You go to the right and you increase it for whatever reason, which we're going to talk about in a second. It's actually going to increase the symptoms of parasympathetics. I mean wet. I mean, you're crying all over the place, you're vomiting, you're pooping your brains out, like all that stuff. That's actually what parasympathetics is going to do. So now there's this little enzyme, which is called acetylcholinesterase, which is actually an enzyme. I call it the Pac-Man. Not everyone calls it that, but what its job is to do is to go around and chew up acetylcholine that's sitting around. You don't want it sitting around forever. You want to get rid of it because you don't want to induce too much of your parasympathetics of having these wet symptoms. So what can actually happen is if you kill the Pac-Man, then acetylcholine essentially just going to be sitting around and it's going to rise extremely quickly. And this is actually what causes the parasympathetics, and it causes these wet symptoms. That's exactly what organophosphate poisoning is. It latches on to this acetylcholinesterase and it kills it. And if you kill that Pac-Man, the acetylcholine is just going to be sitting around and it's just going to go up and up and up and up and cause these wet symptoms. That's what organophosphate poisoning is. Okay, so what we're going to do is we're going to kind of pull this all together. So in the vignette, or someone who comes in the hospital, their background's either going to be a farmer or a pesticide worker. If you see that, this is a big hint that they're talking about organophosphate poisoning. So you're going to have wet signs, like I said before. They're going to be crying, sweating, vomiting, peeing, pooping, drooling. Any way you can get liquid out of your body, it's going to be doing that in excess. I mean, you have so much acetylcholine that it's going to increase these wet symptoms to the point of just it's so excessive and it's really disgusting. That's what's going to be described in the vignette or what you're going to see in the hospital. Like I said before, essentially it kills the Pac-Man, therefore it can't chew it up, and acetylcholine is going to increase. So what do you need to do? You need to get rid of all this excess acetylcholine. So the whole point is you need to kill it. So you do this through 2 drugs, okay? So you want to stop acetylcholine, and then actually if you put these letters together, the A, the T, and the O, and the P, if you put them together, it looks like atropine, which is an anti-cholinergic. Well, that means anti-acetylcholine. So it stops the ACH. So atropine is going to be 1. The next one is you want to prevent acetylcholine. So use the P, the R, and the A, and if you group those together, that's going to be pralidoxamine. I can't say that, my bad. I butchered that pretty bad, but you can read it and look up how to say it yourself. And this is actually going to regenerate the Pac-Man. So if you regenerate the Pac-Man, it's going to be able to go around and start chewing up the acetylcholine, so it's no longer sitting around. If you give these 2 drugs, you'll actually be giving the antidote to fix this abundance of acetylcholine that has actually been sitting around because the organophosphate hooked onto the Pac-Man, killed it, therefore acetylcholine went up, and now you need to do the opposite and get rid of all that excess acetylcholine. And you do that through atropine and the other word that I can't pronounce, which is pralidoxamine. Main point, get rid of acetylcholine. That's the whole point. Just think organophosphate, think a farmer has animals, think A. You have too many animals, you have too much acetylcholine. That's the best way to probably put that with the memory hook. Okay, real quick, anticholinergic poisoning. This is actually just the opposite of organophosphate poisoning. So if you were to take way too much atropine, which is actually going to help get rid of acetylcholine, you're going to be lacking that. So you're going to have low acetylcholine. So if you're paying attention to this video, you're probably going to guess what the symptoms are. It's actually going to be a ton of dry symptoms and not a ton of acetylcholine. So you're going to have increased heart rate, blood pressure. It's going to be dry. They're not going to be sweating. They're not going to be peeing and pooping and what have you. Essentially, it's like someone running from a bear without actually doing the physical intensity of the sympathetic fight or flight system kicking in. So again, you want to get something on board to make sure that you can actually increase acetylcholine. You don't have enough. So what you need to do is you need to get rid of Pac-Man. So if you look at anticholinergic poisoning and take these letters and put them together, you want to attack Pac-Man. You want to physically attack them, and this is done through physiostigmine. What actually it does, it's actually a double negative. So if you kill the Pac-Man that kills acetylcholine, if you get rid of that, the acetylcholine will actually increase. And you can read that at the bottom here, that it kills Pac-Man, it can't chew up acetylcholine, thus it's going to increase, and it's a double negative. I know this one's a bit of a pain in the ass to wrap your head around, but just try to remember that if you have anticholinergic poisoning, you want to attack the Pac-Man, and you're going to do this through physiostigmine. I know this one's a little hard to kind of buy, but this is the best I could do with anticholinergic poisoning. And this isn't really one of those most common ones that you're going to see, but I wanted you to at least have an idea of how to handle it and the physiology behind it. Okay, so now we're on to antidepressants. So this is called tricyclic antidepressants, which are called TCAs. So an example of this would be amitriptyline. And if someone's depressed or has major depressive disorder or what have you, they can take TCAs. These are actually not the main antidepressants we use anymore. We have other antidepressants that actually works much better and have less side effects. But if someone has these for whatever reason and they overdose on them, it could spell big trouble. So the symptoms you're going to have is going to be altered mental status, they're going to be lethargic, and the list goes on. It's not going to be very specific. The main concern is you want to look at their EKG. It could actually develop a ventricular arrhythmia. So I'm not going to go into the pathophys or the cardiology of what ventricular arrhythmia means, but if you start seeing that and they give you an EKG and they say they have an overdose, start thinking TCAs, that someone just ate a whole bottle of this. So the treatment for this is going to be sodium bicarbonate. So for me, I know it sounds like a typical stereotype, but if I think of someone that's on TCAs, they're going to be a bit of a sassy bitch if they actually don't take them. So that's actually going to be the memory hook and how to remember to give them sodium bicarbonate. Think TCAs, someone that's on antidepressants, they didn't take them, they're going to be a bit of a sassy bitch. I know that's not the great way to, excuse me, I know that's not the greatest way to memorize this, but for me, I just remember TCAs kind of being a sassy bitch, give them sodium bicarbonate. And you can see in the footnote below here that sodium bicarbonate helps stabilize the sodium fast channels in the myocardial heart cells and can help regulate the arrhythmia. Therefore, it doesn't develop into a ventricular arrhythmia and therefore into a fatal arrhythmia and therefore possibly killing the patient. So that's how you treat it. All right, those are all the drugs that we went through. That was a pretty extensive list. I know I went through that pretty quickly, but I made a nice table and it's on 2 slides. You can see this one and this one. And essentially sums it up for the name of the drug, some of the symptoms, and then the treatment and the memory hooks and how to do that. So I'll go to the next slide so you can see the other ones. So for this is a nice table to kind of group it all together. You can screenshot this, but to really kind of hammer this home with overdoses, I would just watch this video like 1 or 2 more times, really try to kind of get it under your belt as to like what symptoms and what clues are you looking for, essentially how some of the physiology works and how you're actually treating it. You essentially want to combat whatever the drug is actually inducing to counteract it. So that's drug overdoses. I know I didn't do every single drug. I did leave out ecstasy. That one's a bit of a pain in the ass to explain, and I was essentially running out of time to put together this video. But if you like this video and you like the content in it, please give me a like. You can drop a comment below on how I'm doing with these videos. I know I'm still an amateur and how to kind of put this stuff together, but I'm doing the best I can without little instruction. So I hope this is helping with your studying. I thought this was a neat topic to talk about. I do love toxicology. It is really fun to talk about. And these questions do pop up. And if you know what they are and then you know the clues based on the pupil size or, you know, a nystagmus or what have you, this is actually a big help in getting these questions right really quickly so you can spend time on other more difficult questions to get those right. So yeah, if you like this video, click the like button. If you want me to make more videos, please subscribe. It'll actually give me a good litmus test to let me know if you guys are more interested in me making more videos. All right, I'll shut the hell up so you guys can get back to studying. Love you guys. Thank you for watching this video, and I'll try to pump out a few more. And if there are any topics you want me to try to tackle that haven't been tackled by other people on YouTube, then just drop a comment below. All right, happy studying and good luck. Till next time. All right, peace.